start you in supine. We're gonna do, We're gonna start off with our range of motion for the elbow for both flexion and extension. This is gonna take place in supine. So what I recommend is rolling up a small towel, and you're gonna place it underneath the humerus, especially for extension. That will allow the forearm to really rest into its fully extended position. For both flexion and extension, we're going to use the same landmarks. So we're going to use the lateral epicondyle of the humerus for the axis of rotation. We're going to use the greater tubercle for the stationary arm, and we're going to use the styloid process of the radius for the moving arm. So for flexion, I could either ask my patient, go ahead and bend your elbow all the way, or I could bend it for them. For this one, depending on the size of your patient, you may be able to safely maneuver them passively with one hand. I just generally tend to be in the habit of always using two hands for passive motion, just to make sure that I'm fully supporting them. And then once I'm here, I'm assessing for the quality of the end feel if I'm doing this passively. Pretty good squish. I can see that her forearm is approximating up into her biceps, and that's going to stop that motion. So then, utilizing my landmarks that I've already pointed out and palpated for, she's got about 150 degrees of elbow flexion, which again, normal can be really anywhere from 140 to 150, or it could vary if your patient is more of like a bodybuilder type build. So you just kind of have to assess. And then for passive motion, I'm just gonna let her arm hang straight as long as she's comfortable there. If she needs some more support, I could always prop up a little bolster or use a pillow to support her arm if this were a painful position for her. But then landmarks are exactly the same. Oops. You can see her tendency to want to rotate there, so I'm gonna have to stabilize her arm at least a little bit to make sure that I'm not getting any rotation through the humerus. And that is 0 degrees, actually. 1 degree of hyperextension there. And that makes sense, because if I look at her, it does look like her arm is a little bit hyperextended. So my number on the goniometer should line up with what I can see visually. Now, of course, body mechanics wise, if I could plug this table in, yes, I would raise the table up in order to get more eye level so I'm not creeping down like this. But you guys get the idea. Okay, so that's range of motion for the elbow. Now let's look at some manual muscle tests for the elbow. So for the triceps, Jesse, I'm going to have you go ahead and flip over onto your stomach. And now I'm going to have you scoot toward me just a little bit. Perfect. We're going to let the arm hang off the table. Actually, I lied. Go ahead and scoot back the way that you were. Yeah, perfect. So I want the elbow off the edge of the table, and I want the arm to be abducted about 90 degrees or so. So from here, her tricep is perfectly exposed, so I can ask her to go ahead and straighten out her arm at the elbow as best as she can. I can palpate for that muscle working and observe that yes, she has full range of motion. Now, I'm going to ask her to go ahead and straighten out most, but not all of the way, and I can even guide her to the position I want her to hold. Excellent. I'm going to stabilize over the humerus and apply pressure toward elbow flexion. Hold this position. Don't let me push down on your arm. Ready? 1, 2, 3. Push up, push, 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 push. Excellent. Relax. 5 out of 5. Left elbow extensor, MMT, no pain reported. Okay. And that's it for lying down on the table for all of our demonstrations. Everything else we're going to do either sitting up or standing up. Dealer's choice on that. But for now, Justine, go ahead and let's have you sit all the way up, legs off the edge of the table. Perfect. And again, I would at this point lower her all the way down so that her feet were on the floor and supported. Now for MMTs for elbow flexors, like I mentioned in lecture, we're going to do 3 different positions so that we can bias the 3 different primary elbow flexors. When the forearm is supinated, what muscle am I biasing? Biceps. Brachii, yep. When the forearm is in a neutral position, what muscle am I biasing?
Brachialis.
Brachioradialis. When the forearm is pronated, brachialis. Does that make sense as to why? The first one's pretty easy, right? Biceps brachii is a supinator, so if I position them in supination, that would be biasing that muscle. Why would a neutral position bias brachioradialis over brachialis? I don't know.
the it inserts, it would make sense that it would only go to that far.
Yeah, based on its action, it really is able to either pronate or supinate, but only up to neutral. So if I position it in neutral, that's its limit. That's where it's gonna stop at the forearm. So I am activating, and I can, when we do the MMT, we'll palpate and see that muscle working. Versus in pronation, are there any elbow flexors that also are pure pronators? No. So we only have one elbow flexor left, and that's brachialis. Since it is neither a pronator or a supinator, by positioning the forearm in pronation, which none of the other elbow flexors does, I can bias just brachialis. Does that make sense?
Yeah. Is brachioradialis the beer holding muscle? Or what is that? Like this thing beer holding. I heard of it before.
I haven't heard it phrased quite like that, but so be careful with that one, because in terms of like this motion, that's not what brachioradialis does. This is a wrist movement, right? This is abducting the wrist, right? But brachioradialis only goes up to the styloid process of the radius. It doesn't cross into the hand. Ooh, my hands are dry and flaky. I've been washing them a lot. So in this sense, no, that's not brachioradialis, but in terms of flexing the elbow in this position, like a hammer curl, or if you guys have heard of that exercise at the gym, that's brachioradialis. It's a hammer curl with the forearm in a neutral position. Versus like preacher curls with the palms up, for example.
Just taking the beer and bringing it down.
Yeah, this brachioradialis.
Yeah. Like
This
just
not
holding it.
brachioradialis. So
Okay.
as long as we have that distinction.
Okay, yes.
Yeah.
I've never
Because
heard
it's
of
rad
that,
to hold
but
beers.
That's interesting.
That's
There you
interesting.
go. So with all three of these tests, like I said, you can do them sitting down. You could also do it with the patient standing up. In either case, your patient needs to be able to fully bend their elbow, so there can't be anything obstructing them. And as a result, you're going to need to stabilize the elbow with one of your hands. So let's actually show it standing up, Justine. So go ahead and just stand here by the table. So let's do biceps brachii first. So this one, palm is facing up. So Justine, with your palm facing up, I want you to show me how far you can bend your elbow all the way up and down. Perfect. Go ahead and do that one more time for me. Excellent. Wonderful. So I confirmed that biceps muscle belly is working there. If she were to have done this, I would have cued her to keep her arm a little bit closer at her side, or I could even have her just gently hold onto a towel. That way I know that her arm isn't flexing, or excuse me, her shoulder isn't flexing during that motion. So if you need a little anti-cheating device, you can always use a towel. So at any rate, we assessed full range of motion and palpation. So now we're just going to bend halfway. So just bring your palm facing straight up. I want you to hold that position. Now I'm going to stabilize one hand on the humerus so that her arm doesn't flail all about, and the other hand is going to be pushing down to try and straighten out her elbow. Ready? I'm going to push down. I want you to hold this position. Don't let me move you on the count of 3. 1, 2, 3. Push up hard. Push, 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 push. Excellent. Wonderful. Any pain with that?
No.
Great. So then we do the exact same procedure for the other ones, but just to kind of cut things a little bit shorter. For brachioradialis, palm faces in, hold, don't let me push down, push up, push, 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 push. And look at that. If you bring the camera in real close. Yep. So do that one more time just so they can film it. Ready? 1, 2, 3. Push up, push, 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 push. There's brachioradialis right there. That's the muscle belly, and it comes all the way down to the styloid process of the radius. I want to point that out because I've had one student from each of the past 2 cohorts. When we get to this skill comp, I know you guys are all fried. It's finals week. Everyone is losing their minds. But I've had at least one student from each cohort get brachioradialis MMT and palpate up here for brachioradialis. I want all of you guys to remember, brachioradialis muscle belly is down here, and you just saw it. Brachialis is here, biceps brachii is here, up in the anterior humerus, and you can feel them. But brachioradialis, you better be palpating over the lateral forearm, or I'm going to say you didn't palpate in the right spot. And you guys, we're not gonna have that problem. So then again, brachioradialis, same position, but now the palm is facing down, and I would palpate just slightly medial of the biceps, and then I would push down. Ready? 1, 2, 3. Push, 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 push. Excellent. And then relax. So those are the 3 different elbow flexor MMTs. And that's it for the elbow. Just 2 range of motion, flexion and extension. test the triceps in prone, and for the elbow flexors, you can do it in either sitting as long as the patient is not obstructed by the chair or table in any way, or you can do it standing. Just make sure that you stabilize the humerus with your MMTs so that their arm doesn't flail all about, and as you're assessing range of motion, make sure they don't go into more shoulder flexion as they bend their elbow, which most people won't do, but every now and again you might see that as a compensation. Any questions on lab procedures for the elbow? All right, let's move on to the forearm. And for this one, Justine, I'm gonna have you go ahead and take a seat on this chair and then just rest your arm on the table. Perfect. And let me have you scoot forward a bit because I want your arm to be able to hang off the edge here. There we go, that's it, perfect. So we can even scoot the chair forward just so that your back is nice and supported. There we go, excellent. And for this one, where did my other goni go? Actually, for the first time, we're gonna need a different goni. Hang tight, 1 second. We need a flat pronation and supination range of motion. What the textbook says to do is to have your patient start in a neutral position of the forearm. And what you do with a goniometer that's flush with the dial, so it's not jutting out, is you line up the dial with the styloid process of the ulna. The moving arm just stays flush to the back of the wrist, and the stationary arm just stays vertical. So Justine, when you're ready for me, go ahead and turn your palm facing down towards the floor all the way for me. And you just follow that so you can see the fulcrum just stays over the styloid process of the ulna. The moving arm just stays flush across the back of the wrist, and the and the stationary arm just stays perpendicular with the ceiling there. So then we have her hold at end range. There we go, perfect. And then we take a reading there, and she's at about 90 degrees there. For supination, we just move to the other side. So same idea, we find the styloid process of the ulna on this side, keep the moving arm across the front of the wrist, and the stationary arm perpendicular to the ceiling. Go ahead and turn your palm all the way up for me, facing up towards the sky. There you go, perfect. So then we just have the fulcrum centered over the styloid process of the ulna. And she is at, I'd call that like 87, 88, so mostly full. 90 is normal range of motion for pronation and supination. Now, if for some reason you didn't have this type of goniometer in your clinic, then this procedure is not gonna go super well for you, right? We're gonna have a little bit of a problem. So here's the alternative that you can do. It's not perfect, but if you don't have the right tool for the job, then you still need a way to measure it and track it. So what you do is you ask the patient to grab onto a pen or a pencil such that it's sticking out away from the thumb, and the moving arm is now going to track the pencil with the fulcrum centered over the third knuckle, because that kind of approximates the center of the forearm for you, and then the stationary arm is exactly the same. So let's give that a try. Go ahead and hold on to this pencil for me. Just go ahead and make a nice natural fist. Doesn't have to be a firm squeeze. And then let's say this was the only type of goniometer that we had. So then go ahead and pronate, turn your hand all the way down towards the floor as far as you can. So then I'm just going to approximate the center of the forearm utilizing that third knuckle. And then I'm going to follow the pen. And now she's got a little bit more. She's got about 97 degrees. So again, there's a little bit of cheating that goes on, because what if she's, depressing down with her knuckles? So it's not perfect, but it is a reasonable alternative, and as long as you're staying consistent, then you'll be able to track changes over time, and it gets you at least in the ballpark. So we're going to use this goniometer though, so that we can get the best possible measurement and really focus just on movement of the forearm and not accidentally get any extra movement that might be happening in the hand. But I just wanted to show you an alternative way that, like, okay, my clinic doesn't have this, or it's not available, or it's broken. Okay, I have something else that I can do that'll help me get an idea for this. All right, so that's the range of motion, which again you can do actively or passively. Now the MMT. For the first and only time, 2 hands are on the patient for the MMT, not for stabilization, but for actually performing the procedure in terms of applying resistance. So we start out the exact same way that we always do. Let's say we're gonna test resisted supination. I'm gonna pick a supinator muscle, which could either be supinator or biceps brachii, for example. Everybody pretty much always chooses biceps brachii because it's really easy to find. As she supinates, yep, there it is, popping right out underneath my fingers. You can all see that. So now when I want to do the MMT, go ahead and sit up nice and tall for me. So we want to make sure she has enough of her forearm hanging off the table because we are going to wrap our hands around her distal radial-ulnar joint. So when she tries to supinate, I'm going to try and push the distal radius inward as she's trying to push it outward, right? So Justine, I want you to try and push your palm up so that it's facing upwards towards the sky, like as if you're holding your hand out for candy when you're a kid. And I'm gonna resist you, okay? I'm gonna try and push your palm to face down towards the floor. Ready? On the count of 3, go ahead and turn your hand as strong as you can. Ready? 1, 2, 3. Push up, push, 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 and relax. Good. And then the opposite would be true for pronation. I could palpate for either pronator teres or deep onto pronator quadratus as she turns her hand, or as she rotates her hand down. And then to resist her, she's going to be pushing her radius inward, and I'm going to try and push it outward. So I've got 2 hands on her. This hand is now going to be applying most of the pressure to her radius. My other hands are simultaneously stabilizing and kind of using the ulna for leverage, right? So if we think about other joints of the body where we're testing for rotation, like let's say the shoulder, for example, when we test internal and external rotation, we don't do that with the arm down because we'd have to do this kind of technique where we grabbed onto the humerus with both hands to try and twist it. Instead, we position the elbow at 90 and then we use the forearm for leverage, right? We can't do that at the forearm. There's no way to modify this position in order to get better leverage. So for this reason, we have to have 2 hands on the patient at about the same spot. One hand, or my hands are going to be simultaneously applying that resistance to the radius either way and kind of fixing the ulna. And that's the best that we can do for that MMT. So it's kind of a weird one. It's not too hard. I mean, physically speaking, it's a pretty easy MMT to do. But most of the time, showing one hand to stabilize and one hand to apply resistance looks very clear. And this one, since my hands are so close together, it's a little bit harder to visualize, but the process is not too bad. And that's it for today.
All right.
2 range of motion techniques for the elbow and forearm, and 4 MMTs for the elbow, 2 for the forearm. Not too bad, right?